Now I am pleased to introduce Rob Roscoe for insulin injection technique, the importance of site rotation, and a summary of the randomized control trial. Rob is a pharmacist and certified diabetes educator working with his own consulting firm and is affiliated with the Diabetes Education Center at St. John Regional Hospital. Rob also provides one-on-one collaborative diabetes education and diabetes medication management within family physician offices. Rob will be discussing basic steps in proper injection technique and will identify the typical errors made. A sincere thanks to Roche Diabetes Care, who brought us today's session. Over to you, Rob.
Welcome to today's topic on insulin injection technique. More importantly, the importance of site rotation, as well as a quick summary of a randomized control trial that looked at a tool that could potentially improve site rotation. These are my disclosures. And today's objectives are going to be fivefold. Basically, understand the basic steps in proper injection technique. And what are the typical errors we see made in injection technique? Identify what is lipohypertrophy and why it's important. Understand how injection technique can affect glycemic controls. And again, a quick review or summary of a trial of a potential tool to help improve site rotation. So we've known for years that injection technique matters. So how insulin is injected is as important as the type and dose of insulin. So as you can see, the 4th edition of the FIT recommendations are now online. And it has two components. One is the actual recommendation, which is a point, easy to follow form on different topics, as well as 2 different tools, one for you and one for your patients, on different components of injection technique. So what is the components of a good injection technique? Well, know where you can inject, and choosing a good site is important. So choose a site that's soft and not hard. Adopt the golden rule of proper daily site rotation, so don't inject it in the same site over and over again. Use the shortest needle possible, preferably a 4mm needle. Do not reuse your needle tips. Avoid injecting into lumps and bumps. Those are those hard spots called lipohypertrophy to allow them to heal and go away. And again, don't push in too hard. Try to use the right amount of force. And a little bit new concept that, maybe try to adapt a yearly review, because new information and new products start to come on board, and they may change the information that we're providing today. So it seems easy enough. So why is it such a challenge for people with diabetes to remember this? If you think of a typical person with diabetes, they have so many decisions in the run of a day. It could be anywhere from 50 to 200 decisions based on their diabetes, from where is my blood sugar, what is my dose, what am I going to have to eat, to why am I feeling this way, that you can see how injection site rotation can get relegated to a less important role. And even right from the start, when the person is learning how to start injections, you can see that there's an information overload. So they're more worried about how's it going to feel? What happens when I go low? How do I change my dose? What happens if I take too much insulin? So the role of site rotation gets relegated very low, if they have any education about it at all. And this is because we don't have a good resource in terms of using it on a day-to-day basis with the patient to remind them to do their site rotation. So between a lack of a resource and the unmet need of an easy tool, site rotation sort of needs another tool to boost its importance. This is kind of emphasized by a Canadian observational trial just recently released that involved 24 physicians and 230 adults. On the physician side, we were looking at the attitudes and the importance they thought of injection technique, and the same thing on the patient side, but we were also looking at the challenges a patient would have to feel when they're doing their injections. And as we found out, every patient had at least one injection technique error. Most had a combination of 1 to 3, but today we're going to concentrate mainly on the second bar here, the size and the role of injection site rotation. And this study actually brought out a role that actually 60% of insulin users reported injecting only into one site at any particular time. So it's kind of interesting that the theory is well known, but the practice is not readily followed. When we've surveyed certified diabetes educators, is their site rotation important? It's easily seen by the green bars that over 85% of CDEs thought that this was a very important role. But did they have a good tool to teach or use? With the blue bars, you can see they're all over the place. So nothing really go to in terms of using a particular product to help teach. So the bottom line here is that lipohypertrophy is a common local complication of insulin therapy that has a prevalence of at least 50 to 60%. And the strongest correlation is a lack of injection site rotation. So let's take a quick step back. What is lipohypertrophy? It's just basically accumulation of fat tissue underneath where the skin where people do their injections. It presents as kind of a thick, rubbery swelling of tissue that can be either felt or not seen, or they could sort of see and touch as well. So in this case, patients should actually be taught to self-examine themselves as well, because they may see the lipohypertrophy, but more importantly, they may be able to feel them even though they can't see them. They show up early in patients, and under 5 years, we can have 48% of patients start to show them. And it makes sense that type 1s would have a higher incidence because they're injecting more than type 2. But the cumulative rate's around 60% of people with insulin therapy will have lipohypertrophy. Other studies looked at different prevalence rates, and you can see it ran from 40 to 60%. I use the basic rule that basically I think of every second patient that's on insulin may have an issue with lipohypertrophy. So if I see 8 patients in one day on insulin, I kind of assume that 4 of them may be challenged with lipohypertrophy. So why is site rotation important? Well, if you do an injection, as it starts to heal, it's considered a micro-injury, but it's doing the healing in the presence of insulin, which is a growth hormone. So logically speaking, if you do too many injections in too close a spot, as it starts to heal, you're going to get an overgrowth of fat tissue underneath the skin, and therefore that develops that lipohypertrophy. So why is it important in terms of clinical repercussions? Well, when you're injecting into the lipohypertrophy, insulin doesn't absorb well. And because of that, they get glucose variability. And this frustrates the patient immensely. So they have days where things are working well and days where they don't. And they don't understand it because they're doing the same thing day in and day out. So they start blaming the meter, the insulin, and not realizing that it just could be a simple role as their injection technique. Because insulin's not being absorbed consistently, you can have unexplained hypoglycemia. Also, when you're injecting into the lipohypertrophy, because of poor absorption, you may not get the results that you're looking for in terms of insulin therapy, and your A1C tends to drift up, which means that most clinicians will start raising the insulin dose, which actually could increase the role of hypos and variability versus going back and looking at the simple role of rotating better to get better results. So the bottom line here is that studies indicate the most important risk factor for patients that experience lipohypertrophy is simply a failure to rotate their sites. And this is borne out by this particular trial that actually looked at people that rotated correctly, only 6% actually had lipohypertrophy. And in patients that had no or poor rotation habits, almost 95% of them had some degree of lipohypertrophy. So simply, if we have better technique, we can improve outcomes. So number one, by not reusing the pen needles is important. Make sure we're using the 4mm needle tips. And then more importantly, give them some degree of education about the importance of site rotation, has the potential to lower A1C, also has the ability to avoid lipos from developing and allow those that are there to start to shrink by not injecting into them to allow them to start healing. And thus we actually can use less insulin with an improvement in their glucose control. Remember, it's the potential, but we have to get that practice into everyday practice. The role of A1C dropping, it can be significant. You can see in different trials, it goes from 0.5 to 1%. That's the same as adding a brand new medication, but in this case, we're not adding anything. All we're doing is using their current therapy, but using it more effectively and more wisely. So this is right out of our recommendations. So basically, to prevent lipohypertrophy and maintain consistent absorption, patients should be assisted in the development of a personalized structured rotation regimen for injection and insertion sites. Very important. The second role is basically if they're going to stay in one location to separate their dose by at least 1 finger width apart. And this leads into the summary of that randomized control trial, that a recent trial of colored pen needle tips accompanied by education and information significantly improved injection site rotation. So if we look at this Canadian trial, we looked at 15 sites across Canada with 203 patients. The patients, when they came in, they were either relegated to use their existing needle tips or they were provided a new needle tip that had multicolors and was considered a tool. One important part here is that the healthcare professionals involved, in this case pharmacists, were instructed not to provide any further information beyond just handing the tool out because we wanted to measure the effectiveness of the tool and did it have an effect in improving rotation. The secondary outcome was really important as well because we're looking at, did the pharmacist in this case learn more about site rotation and they actually understand the importance of reviewing site rotation and lipohypertrophy with the patient. The results were statistically significant that just by using the tool alone without further education or counseling, we had almost a 20% increase in terms of improved site rotation. So 54% on the site rotation with the colored pen needle tips. Patients were relating to or kind of resonated with them that when they choose a different color, they would choose a different site. So every time they choose a color, they would look a different color and chose a different site to do their injection. Also in the tool talked about the reuse of needle tips. So just by looking at the information, we had a 25% reduction in the people that use the tool and reduction in terms of reuse of the needle tips. In terms of the pharmacist input, to me, this is very important, that the comfort levels in terms of being able to talk to the patient about the importance of different needle tips went from a low before study of 30% to a high of almost 95% after. So actually having better conversations with their patients. This also related to the role of lipo hypertrophy because they understood the role of the needle tip. They understood much more importantly the role of lipo hypertrophy in terms of diabetes management, and also the role that diabetes site rotation had in terms of lowering the risk of lipo hypertrophy, went from a low of 31% to actually understanding the importance of that to 95%. So much so that after the trial was done, that 75% of pharmacists intended to continue counseling patients when they're picking up their needle tips on the importance of site rotation and the role of lipo hypertrophy. And to us, that was a win-win situation, both for the patient and for the healthcare professional who learned the importance of site rotation.